All right, welcome everyone. So today we'll be talking about internal medicine boards, especially for ABIM exams. So let's get started. So let's say you see a young patient who is coming to you for hypertension, and his initial blood pressure was 180 over 90s. You started lifestyle modification and antihypertensive drug, and on follow-up visit, his blood pressure is still high, 160 over 80s, and he has normal exercise tolerance, he's asymptomatic otherwise, he's young. What other test would you order if you hear S4 gallop rhythm on auscultation? So now you might be thinking about ordering echocardiogram. Let's say this patient is young, though asymptomatic, has normal exercise tolerance. Echocardiogram is not indicated. Even if you get an echocardiogram and if that shows diastolic dysfunction, that would not change your management. And it's very unlikely to get HFrEF if the patient is asymptomatic and has normal exercise tolerance. So no additional testing is indicated at this point. So actually S4 gallop rhythm is the most common physical finding on cardiac auscultation in patients with hypertension, so that doesn't warrant any further evaluation. Now, let's say a 50-year-old woman is coming with elevated blood pressure to your office, and the blood pressure is around 135 over 85. And on fundoscopic examination, you see AV nicking. There are no other abnormalities. Her HbA1c is 6.0, and her creatinine is normal, her electrolytes are normal. So, would you start this patient on antihypertensive drugs? What should be your next step in management? So, in this scenario, by definition, this patient has stage 1 hypertension, right? Stage 1 meaning blood pressure is between 130 to 139 systolic, and diastolic is between 80 to 89. These days, the guideline recommend that you don't need to start antihypertensive right away. You can start lifestyle modification first, but you need to start those antihypertensive drugs if the atherosclerotic cardiovascular disease risk or ASCVD score is more than 10%, or if the patient has diabetes or chronic kidney disease or some known ASCVD or some end organ damage. So this patient had AV nicking in fundoscopic examination. That's actually an indication to start the antihypertensive drugs, but you have to first confirm the discrepancy in the blood pressure which you found in the office, and this patient may have outside elevated blood pressure. So how would you do that? You can either order ambulatory blood pressure monitoring or ask the patient to check her blood pressure at home. So that's home blood pressure monitoring. Okay, so either way, you have to see if the office blood pressure are maybe in stage 1 hypertension zone, but if the outside of the office blood pressure are in 160s, 180s, so you have to target the outside office blood pressure, because if you target the in-office blood pressure, that would be misleading. So to sum it up, what are the indications of antihypertensive treatment? So number one, if you have stage 1 hypertension, what is stage 1 hypertension? Systolic more than 130 and diastolic more than 80. So if you have stage 1 hypertension, you can start antihypertensive drugs if ASCVD score is more than 10%, or if you have clinical evidence of ASCVD, like patient has coronary syndrome, ischemic heart disease, heart failure, stroke, or peripheral arterial disease, or if the patient has type 2 diabetes mellitus, CKD, or age is more than 64 years. Okay, so these are the patients you want to start antihypertensive drugs. For other patients, you can just offer them lifestyle modification. But if the patient has stage 2 hypertension, that means if the systolic is more than 140 and diastolic is more than or equal to 90, you actually have to start this patient on antihypertensive drugs. Now, let's say you have an elderly patient who is on some ACE inhibitor, diuretics, and alpha blocker for BPH, who is coming with several falls which are preceded by lightheadedness. What would you do next to confirm what is the cause of fall? You check orthostatic hypotension, right? You check for orthostatic hypotension, you check the blood pressure while the patient is lying down, and then you check the blood pressure when the patient is standing up. So this is more of an orthostatic hypotension, and alpha blockers are notoriously known to cause orthostatic hypertensions, particularly in older patients. So you have to check for that in older patient who is coming to you with syncope or pre-syncope, especially those who are on alpha blockers. So if the patient has prodromal symptoms before they pass out, like for example lightheadedness or sense of warmth, is that a cardiogenic syncope or non-cardiogenic syncope? It's a non-cardiogenic syncope, right? If you don't have any prodromal symptoms and then you pass out, that's a cardiogenic syncope. Now, what would be your diagnosis if a very young female, let's say 18-year-old female, is coming to you with severe elevated blood pressures like 180 over hundreds, and blood pressure is equal on both extremities, and you palpate dorsalis pedis pulses, which are both symmetrical and bounding, and there is no detectable radiofemoral delay. All the labs, including CBC, BMP, thyroid functions, and inflammatory markers, everything is normal. So, what's the cause of hypertension in this very young female? Your answer should be fibromuscular dysplasia. Now, actually, you have to think about primary hyperaldosteronism, more elderly patients, and the clue in the labs would be because you have high aldosterone, right? So, aldosterone would absorb salt and water, and it would excrete proton and potassium in the urine. So if you excrete proton in the urine, you would have metabolic alkalosis in the blood. If you also lose potassium in the urine, you'll have hypokalemia. And since you're absorbing sodium, you'll have mild hypernatremia. And of course, you're absorbing sodium and water that will lead to hypertension. So you have to think about primary hyperaldosteronism in patients who are having concomitant metabolic alkalosis, some mild hypernatremia, hypokalemia, especially in older patient as a cause of secondary hypertension. But in this very young female, it's especially in the age group of 18 to 39, it's usually secondary cause of hypertension, but in her case, since thyroid function is normal, kidney function is normal, so it may be other causes of hypertensions like renovascular hypertensions like fibromuscular dysplasia. What will you think if the blood pressure is lower in the lower extremities than in the upper extremities? That's coarctation of aorta. And what do you think will be your diagnosis if you see a young Asian female, no significant palpable pulses in the radial arteries, who is coming with hypertension, ESR is elevated? That's Takayasu arteritis, right? Large vessel arteritis. So what's your diagnosis if a patient is coming with elevated troponin, blood pressure of 220 over 120, patient is having diffuse pulmonary edema, and patient is also short of breath and has chest pain? Is it hypertensive urgency or hypertensive emergency? This is hypertensive emergency, right? So how do you define hypertensive emergency? When you have systolic more than 180 or diastolic more than 120. Remember, it's systolic more than 180 or diastolic more than 120 with evidence of target organ damage. That's hypertensive emergency. And if you don't have evidence of target organ damage, that's hypertensive urgency. So this patient has hypertensive urgency and pulmonary edema. What's your next step in management? Would you choose IV nicardipine or IV nitroglycerin? It's actually IV nitroglycerin is preferred here. Now this patient has pulmonary edema, right? If you give IV nitroglycerin, that would reduce preload by venodilation. It can also do some of the arteriodilation. It will reduce afterload. And with the coronary arterial dilation, it can also help if this is acute coronary syndrome, right? So nitroglycerin would be particularly beneficial here because it will reduce preload and eventually help in alleviating pulmonary edema, especially this patient has acute heart failure. IV nicardipine you can choose. I mean, it can rapidly lower the blood pressure, but might not be the best choice of drug in this scenario because nicardipine can cause arteriodilation and it can cause reflex tachycardia and actually do more harm if this patient has acute coronary syndrome. Would you use IV labetalol in this patient? Actually, we should avoid, and rather it's contraindicated if the patient has acute heart failure. So in general, if the patient is having hypertensive emergency and they have acute coronary syndrome or pulmonary edema, usually nitroglycerin is kind of something which is preferred. What would you give if the patient has acute aortic dissection and hypertensive emergency? You give IV esmolol or labetalol. And for other cases, right, like for example, if the patient has hypertensive emergency and ischemic stroke or severe eclampsia or preeclampsia, you can use IV labetalol, or also you can use IV nicardipine. Let's say you are seeing a young female who is coming with severely high blood pressure and you decide to work up for secondary hypertension. Now in the labs you get BMP, her bicarb is normal 29, plasma renin activity is very high, and creatinine is just slightly elevated. So if I say bicarb is normal, plasma renin activity is high, what would you choose? Is it fibromuscular dysplasia or primary hyperaldosteronism? It should be fibromuscular dysplasia, right? In primary hyperaldosteronism, since there is lot of aldosteronism, it will give a negative feedback to renin. So renin should be high or low? It should be low, right? So renin activity should be low and aldosterone should be high in primary hyperaldosteronism. Whereas in fibromuscular dysplasia, since the renal blood flow is diminished, you'll have very high renin activity. What's the best initial test for renal fibromuscular dysplasia? Duplex ultrasonography, right? And or CT angiography. What's the first line antihypertensive therapy if the patient has stage 1 hypertension and diabetes? Along with that, the patient has chronic kidney disease and some albuminuria. You'll use ACE inhibitors or ARBs, right? So you also have to keep in mind that these days SGLT2 inhibitors should be also considered. These are also the class of drug which has been shown to slow the progression of kidney disease, especially diabetic kidney disease. What test will you get if you have an elderly patient who has history of episodic headaches and sweating and palpitations coming with blood pressures of 220 over 110? She also has pulmonary edema and saturating around 90% on 6 liters of oxygen. The echocardiogram actually shows severe and diffuse apical wall motion abnormalities, but the bases are intact. That means there is preserved function of the cardiac base, almost like a Takotsubo cardiomyopathy. So what test would you like to get in this patient with hypertensive emergency? You should get urine or plasma metanephrines, right? So this patient has severe hypertension and acute heart failure and a typical history, right? This patient has also have episodic headaches, sweating and palpitations. And the echocardiographic finding in these patients are similar to stress-induced cardiomyopathy, also called as, apical ballooning syndrome or Takotsubo cardiomyopathy. And the EKG changes in this patient you can see would be some ST elevations or T wave inversions in the precordial leads. What screening test would you order in patients more than 65-year-old with the history of smoking? As per USPSTF guidelines, you should order one time AAA screening, right, by ultrasound. So in men's 65 to 75 who have ever smoked. So the definition is like more than 100 cigarettes, but those who have ever smoked, that's a grade B recommendation. You should get a AAA screening, and if the AAA diameter is more than 5.5 centimeter, that's when you should get a surgical repair of large AAA. Now, different societies like Society of Vascular Surgery actually recommends more aggressive screening criteria. They recommend that you should get ultrasound both for men and women aged more than 65 to 75 who have ever smoked or who have family history of AAA. So you can consider getting a ultrasound AAA as well. But in general, as per the USPSTF guidelines, you should get screening tests for men 65 to 75 years of age who have ever smoked with the ultrasound of the abdominal aorta. Now let's say if the patient is coming to you with symptoms of orthostatic hypotension and he's taking finasteride, toxazosine, atenolol, simvastatin, metformin, aspirin. Which of the above drug would you discontinue or try to discontinue if the patient has persistent orthostatic hypotension? You would discontinue doxazosine, right? That's a alpha-1 blocker, and that would relax smooth muscles of the prostate and the bladder neck, usually prescribed for BPH. However, it can notoriously cause orthostatic hypotension. So rather, you should prefer more selective alpha blockers like tamsulosin, alfuzosin, or silodosin, which are more selective for the prostate tissue, and they are thought to cause less orthostatic hypotension than doxazosine or terazosin. So in this patient, you should try to discontinue that and see if the orthostatic hypertension resolves, or if the urinary symptoms worsens, you may do some cautious trial of adding one of the selective agent, but that's what you would do. Let's say you are seeing a patient with blood pressure 210 over 110. She is asymptomatic. You do all the labs, including troponin. You check fundoscopic exam, and there's no papilledema. There are no other findings. The CT of the head is normal. Emergency department got it anyway, and even that was not indicated. So what would you do for this patient? So this patient was actually taking hydrochlorothiazide 25 milligram daily at home, losartan 100, and amlodipine 5 milligram. So would you admit the patient, or would you just give her some medication and send her home? You should actually increase her home medication and send her home. So this is what, hypertensive urgency or emergency? This is hypertensive urgency, so you can increase her amlodipine to, let's say, 10 milligram, and later on have a close outpatient follow-up. So this is one of the high value care question, that if the patient is coming to you with hypertensive urgency and there are no symptoms, you can manage this patient outpatient by just adjusting long acting medications, and you just have them follow up on an outpatient basis. Now let's say a patient is coming to you with severe chest pain, blood pressure is high, let's say 180 over 100, severe chest pain which is radiating to her back. What's your next step in management? You would get a CTA of the aorta, and that actually shows aortic dissection, and this aortic dissection is actually beginning just beyond the origin of the left subclavian artery, and it's also extending into the right iliac artery. So what kind of aortic dissection is this? This is a type B aortic dissection. So this patient has what? Acute type B aortic dissection. So what's your next step in management? You would give IV beta blockers, right? So according to the Stanford classification, there are two types of aortic dissection. Type A is it involves the ascending aorta and the aortic arch, and it may also include both ascending aorta and the aortic arch. Type B is usually descending aorta, or the arch which is distal to the origin of the left subclavian artery, and it shouldn't involve the ascending aorta. So type A aortic dissection is usually surgically managed, as well as type B aortic dissection can be often managed medically. However, if you see end organ damage, then you may have to do endovascular stenting or vascular surgery, even if the patient has type B aortic dissection. So in type B aortic dissection, if you see evidence of organ compromise due to vascular occlusion like intestine, kidneys, or lower extremity ischemia, then you would need endovascular stenting and vascular surgery. Okay, and the reason why we give IV beta blockers in aortic dissection is to decrease the shearing stress, that's so-called dP by dt. Okay, so that's one of the mechanism why beta blockers are preferred. And when you start IV beta blockers, what should be your target blood pressure and heart rate? So target systolic blood pressure should be 100 to 120, and target heart rate should be less than 60 per minute. And what's the most common risk factor for aortic dissection? Hypertension. Let's say you're seeing a patient with history of hypertension, hyperlipidemia, and diabetes. Her blood pressure is around 150 over 90. She's currently on 25 of hydrochlorothiazide, 10 milligram of lisinopril, and 500 milligram of metformin, along with 20 milligram of atorvastatin. So her blood pressure is kind of still elevated. Her LDL previously was 130, and after starting atorvastatin is 84. So how would you manage this patient? So now, what's the blood pressure target if you have hypertension with diabetes? Your blood pressure should be, target would be same, right? Less than 130 over 80 in most patients, assuming it can be safely attained. So this patient's blood pressure is still high, and we still have room for going up in lisinopril. So we would actually go up on lisinopril to take care of the blood pressure. Now for the cholesterol, her cholesterol was 130, and the cholesterol, mainly the LDL. So the LDL was 130, and it's now decreased to 84. So there is not 50% decrease. Her cholesterol actually, the LDL just decreased to maybe around 35%. So our target should be more than 50% reduction from the baseline to a target level of less than 70. Guidelines are frequently changing. Now they target less than 55. So since this patient was taking 20 milligram of atorvastatin, we would go up on atorvastatin. That's 40 milligram of atorvastatin. That's a high intensity statin. And if you still think you want to lower the LDL more, and if it's not attained with statins, the second thing you can add is ezetimibe, right? And if the LDL is still high and you want to go down on LDL furthermore, what's the next thing you can add? PCSK9 inhibitors. Let's say you have a patient with a history of long-standing hypertension on maximal dose of carvedilol, amlodipine, and benzapril, and blood pressure is still 155 over, let's say, 85. So blood pressure is still high. What would you do? You would start this patient on one of the important class, that's diuretics, right? Diuretics are most underused class of drugs in patients with difficult to control hypertension. So you still have to add diuretic. Okay, we covered good chunk of information for your ABIM Internal Medicine exam. Thank you for listening, and please check out my YouTube channel, Apurva Popat, and also check out my Instagram page, Dr. Apurva Popat, and my website, usmlestrike.com. Thank you for listening.